So most people would know, of course, about two of the main names, Watson and Crick's, but that actually there's quite a few people, and also I accidentally passed on next slide, but there is Avery, there is Shargaf, there is Rosalind Franklin, and that's the theme. There is nothing on this topic or else that doesn't go with a lot of people. And this is the next phase of that DNA after 53, which is whole genome sequence, against collaboration of these two guys actually behind hundreds of people, and also the pen genome just a couple of years ago, which is the next stage. And the evolution is constant, and of course we are always evolving and going from one to the next. So this is a very well-known picture for a lot of people here, which is how much the genome costs. And now we are going down to what could be a couple of $100 or $300 a piece, which of course opens the massive plethora of applications from cost perspective that was not possible before. And so, but why is one genome not enough? Why are we talking about very large programs? And without being very complicated on this story, but I think Darwin is the beginning of this because of diversity, because of mutations, because of disease, because of the adaptations, and also about something that is here, is how humans moved along, and how when they move along, there is a certain type of genes, certain types of variations that goes into every place, right? And so it's to account for that variation, for the fact that we are not all the same, and we have different mutations, different genomes, that we need to think about this at the population scale, and that's why these programs started, right? And there is quite a few of them here, and this is several programs that are starting, and EGP, of course, with 1 million is just the largest of them all, which is very exciting and extraordinary from the point of view of what we can do here. So sequence once and use it for life in a way is the idea here, right? The idea here is that if you have everyone sequenced once, you can continue to use it, not only on applications that do exist today, but on applications that can come next, right? You have a database, it's there, and you can come back to it. And so, whole population, massive leap forward. DNA sequence is cheap enough. You sequence everyone. You can use it any time and for anything. And that's the Emirati Genome Project, which, of course, run by the Department of Health, with the M42 as the organization that has set up a lot of the work on the ground. So this is just a picture of the project. This is Nanopore, and this is Illumina. We have now sequenced over 700,000 genomes, which accounts for 70% of the population. The idea is to sequence all the population of the Emirati, which is around 1 million people. And so the question here is, you sequence the whole country, which is the first in the world, right? And what will you do? And what you will do? Anyone wants to suggest something from this picture? Anyone? No? Okay. Any ideas on this? On what would be done from this? This is Tay-Sachs disease in 1971. It was the first time where there was a massive problem with Ashkenazi Jews in New York, a disease that is awful. Kids just stop eating, and they don't have the muscles. They cannot, and they will eventually die at 5 years old by just not being able to process nervous systems. And the gene was known, and from 71, the people in the community start to understand who would be a carrier for that, and they stopped the disease. 95% of all individuals from Ashkenazi today do not have a Tay-Sachs disease. 10 years later, after this, 95% of this disease is gone. So that's the first example of premarital screening. It was actually done 53 years ago, so it's not really recent, and it's a massive success. Of course, at 10, you knew one gene, you could type one gene, you could type one single marker, right? Which now is not the case, obviously, and that's the big difference. This is just some examples of still today, maybe because this is not the population at risk, but a couple, not knowing, of course, that they carried the recessive for Tay-Sachs. They ended up married, having a kid, and this is actually what shows, because we talk about this very conceptual, but then when you look into what's happening in people's lives, you see that, that we wouldn't focus his eyes, he couldn't roll over and could take any food that wasn't liquidized. Since then, he has gastrostomy and unable to eat anything orally, and he has lost the ability to swallow. He also has epilepsy, and they're studying having cluster and seizures. That's the type of disease that we are talking about. And that's devastating, of course, for the kids, for the families, for society at large, and cost-wise, very, very problematic for a whole health system that is trying to deal with these patients. So this is, and it is a bit scary, I have to say, when I was writing this, but that is what could be achieved here. No blind kids, no deaf kids, no intellectual disability, no cystic fibrosis, SMA, beta thalassemia, no pediatric cancers, no Tay-Sachs, and no rare diseases. This is indeed what we could get out of premarital screening that would be looking at all these diseases that are known recessives for specific genes. And this is what's being done now by DOH. DOH is the 6th country in the world with the highest rate of genetic birth defects. PMS has been around since 1971. Is better described as PMS-GS because it's genomics counseling. So the programs actually do need to have a genomics counseling and genomics system-based approach. Has been implemented for DOH since 2011. So that is the first, which at the time was HIV, beta thalassemia, sickle cell. And in 2024, it started to be with 570 genes and 84 diseases. And again, it's updatable. New diseases come, and you can continuous update and make sure that the newest version and the latest iteration is engaged. It's going to cover the whole population and could wipe out many rare diseases and not only Tay-Sachs. So this is the first results for 1,000 couples, and this is the diseases. So 11% of the couples were identified as one of the rare diseases that is on the DOH panel. This is the diseases that were the percentage. This is the genes that were typed, and this is the first results of the program and how this is moving forward. This was presented in the American Society of Human Genetics last November. So apart from that, if you're trying to make kind of what is the levers that DOH can work with, the EGP can work with, what are the levers that you can apply? One, of course, is number of diseases. There are 700,000 diseases for rare diseases, and now we are doing 800. Then what are the numbers of causal genes that are known for these diseases? And this is where, because of the fact that this is a very highly powered population, consanguinity, families, typed whole genome sequence, we can have a very strong impact in finding new variants out of the variants that are known for genes. And even more than that, also the genes that are responsible for diseases. There are genes that are not yet known for rare diseases. Again, the GP could have a massive effect on that. And the community adherence, which is this society ready to trust, to have societal alignment, to be transparent, and to have technologies advancements, and to do IVF, genetic therapy, to actually increase the adherence on this. And I have typed the lower bounds and the upper bounds, and the lower bounds will give you 15% of rare diseases, the upper bounds would give you 77% of reduction. And this tells you, again, that if you go for the upper bounds, pushing this lever with EGP, the new variants, the new genes, the adherence, you could get a massive reduction in rare diseases, which would be incredible, actually, for the country, but also for the fact that genomics, the promise of genomics has been there, and this could be realized, actually, through this program. So this is just a summary. And I'm going to let this number, which, of course, would need a lot more. I know that all these numbers are bounds, and I'm pushing the envelope here, but this is the message that, indeed, on an optimistic view, of course, but would be possible. Reduction of 77% of newborn genetic defects in the population. Second part of the talk, again, you sequence your whole country, first in the world, what will you do? What will you do? Any ideas? If you see this picture, what is the idea that you get? Anyone wants to take a peek? I have to say that I had prepared answers, but the three people that I had asked, Monica, it's your cue. What are you supposed to, what are we going to do here? Pharmacogenomics, thank you. We have prepared this, it didn't work very well. Pharmacogenomics. Why pharmacogenomics? You look into these two people, and you can see that they should not get the same dosage for drugs, right? It's pretty obvious. I mean, Shaq O'Neal and Simone Biles should not get the same dosage for any medication because clearly they are very different from one another in terms of mass and in terms of how you get those drugs into their bodies, right? So pharmacogenomics even more than that, right? If you know that you have a certain gene, you're not going to process a drug, so you need to adjust for that. So I look into this and I think, okay, pharmacogenomics is very clear, needed when you're prescribing drugs. And just one example of that, this is one of the most prescribed drugs in the world, is clopidogrel or Plavix, and it's not for everyone, right? Because the drug goes into a prodrug. It's like a molecule that needs to be cleaved by an enzyme. If the enzyme is not work, then you have basically no medication. So you are taking the pill, but the drug is not being processed, and so the active component is not flowing your body, right? And so it doesn't work. Some people get a heart attack or a stroke because the blood thinner is not working, okay? Is this really relevant? Look into this. I've issued drug markets because they did not disclosure Plavix was not active for some people, and Bristol Myers and Sanofi were fined almost $1 billion out of this. And this happened, right? Just tells you how relevant all the pharmacogenomics is, even in terms of the industry world right now. This is a big table. I'm not really going to bother you with this too much, but maybe just an example, again, fluoropyrimidines and DPYD. This is one of the most common cancer treatments. Without if you have the wrong version, the wrong or right, I don't know about wrong or right, but if you have a specific variant, this drug is not going to work, or it's going to work too much. And so you need to adjust. And this is the type of current situation that the EGP can provide, because we can get a report out of this, and then we can provide doctors information so that they can act that in the precise way. This is the bioinformatics pipelines that are used to do this, which I'm sure thrills this audience. And this is a summary. And I would like to talk about this update because we had the first result, and then Wada, that was here before from DOH, pushed us very quickly to update a drug. ApoE4 leads to problems if you have a specific variant of if you have ApoE4 from the ApoE gene. And very quickly, we could turn around the report, include that, so that now the new Alzheimer's drugs can have a pharmacogenomics report that warns doctors about the likelihood or the probability of this drug having a problem. And this was done very, very quickly because, again, you have the genome there. It's not a specific test. You have filters and bioinformatics filters on top of it. Then you apply it to this, and then you move forward. And this is the example of a report. Shrey and Maz were very influential in doing this from M42. And this is an example where the doctor would be warned of how to metabolize the report. But what I'd like to say is that this thing that you're seeing here had been delivered by 160,000 reports in the Emirati population, which is the first large-scale pharmacogenomics delivery into the medical clinical care in the world. So this, again, like the premarital screening, is the direct result and direct benefit of doing a population at this scale. And I think it's going to be very clear very quickly the immense advantage of having these reports at the doctor's desks. Last one. If you sequenced the whole population, what would you do? I'll give you a few seconds for you to read this and to know if anyone knows what this is about. Any thoughts? Any ideas? Genomic screening. Thank you, anonymous, anonymous watcher of this talk. Genomic screening. And with anyone famous would have written this? So this is a story already 13 years ago, right? 12 years ago, where Angelina Jolie, whose mother and uncle have died of breast cancer, knew that the mother had died at 56, and that she knew that she had the BRCA1 gene and decided to do preventive mastectomy because of that. And this, of course, set out, they call it the Angelina effect, which has actually been even proven with papers that people have taken much more about genetic screening in this. And again, this is what you can do at the population level, right? This is all the diseases that right now you can screen for the population, identify screens, and for this there is some kind of action, right? Some of them, like familial hypercholesterolemia, is relatively simple. Statins, and Dr. Sarah Suleiman, and that is very much involved in this conversation, was in the room as well. This one, cerebrotendinous xanthomatosis, is actually very, very rare, but also there is a very tablet that people can take and stop the accumulation of cholesterol in their brains. Or the other things are more complicated on the tune of millions of dollars, like Casgevy for sickle cell disease, or blindness for LCA. And this is an example of one of the first kids that got Lex Turner, and he got cure of blindness. And he was 9, and this is about my last birthday with LCA, because he had surgery, and Lex Turner worked fine, and now he's seeing, which he would be already blind if this was not the case. This is Decode, a paper from Decode, where they went through the genomic screen of population and identified that 4% of the population will have a gene for which there is an actionable act, right? So there's something that you can do in 4% of the people that delays disease, prevents, or at least monitors and makes sure that people do not end up late in the hospital, which is much more severe, instead of having preventive medicine. And this is just bioinformatics pipelines that we have done to possibly act on a genomic screening. This is just the summary. And maybe just a few minutes on the other stuff that you could do. You can do many, many things, of course, because the data is there, right? So this is just possible ideas of many, many more. Drug discovery, methylation, markers in aging, telomere and aging, mitochondrial disease, rare disease, GLP-1 mutants, early cancer, PRS scores that Dr. Alameri just mentioned before, which you can do in every population, and in the area population, and adapt, because PRS scores are very ancestry dependent. We could adapt it here and make sure that we have some preventive number for doctors to understand whether people are at risk specific diseases. You can talk about de novo mutations and structural variants, because we have families within the GP. I mean, this is an incredible data set. Can be used in many, many different ways, from the clinical applications, which I just mentioned, to research, and to drug discovery, and to human settlements. I mean, the Arabia, right, of course, we don't quite know, because people went out of Africa. Sure, we went through Arabia, but then there is an ice age, so people left. Are they coming back from Africa? Are they coming back from Europe and Asia? All those questions could be answered in some ways by this data set. And I think I'm done, right? Is it? Yes, and of course, without the people that are trusting that this is really relevant, and that are trusting that this data set will help their country, themselves, and the world, this will not be possible. And they are really the people that, in a way, made all of this possible. Yes. Thank you. I have 3 minutes for my watch here. So I don't know if any questions? And thank you for the anonymous people that work with me that ask the questions. No? Okay. No questions. Everyone? Okay. I can hear you, but not through the microphone, no. We have not looked into that. Now, you're touching a very, very important point, which is this is the first data set in the world that has families, right? Because you sampled so much from the population, just by genetic chance, right? You're going to have grandparents, parents, and children, which gives you an incredible power compared to others, because this is not really a population study. This is a family study. But a family study to a scale that nobody has ever done. This is maybe the most powerful technical computational biology, genomics aspect of this. It's families, which means that imagine that you have 3 individuals in that family that has cancer. And one is the grandmother, the other is the uncle, and whatever. You can link this as a family and follow where these genes are going. So you effectively have an incredible power because you know where the genes are not and where the genes are. So this for discovery is incredible. I think that for drug discovery, only that, just that, makes this data set absolutely unmatched in the world. Yeah. It? Thank you. Okay. Oh, there's another question. Sorry.
Ask? Yeah, I wanted to ask actually with cancer genetics, you mentioned about screening for cancers. Do you also screen later on as well for those after the onset of cancer? Do you do genetic testing for that as well? Because you talked about the pre-screening part, like before onset of cancer.
We have the whole population, right? So even knowing which people are metastasizing, etc., will be possible in this population. We have not yet, so the genomic screening in your population is not an active program. That's something that we could do. BMS, so the premarital screening, and the pharmacogenomics are active programs that TOH is as decided, but not the genomic screening. But you could definitely go into any metastases, late onset, etc. Because again, you have the whole population, right? So you can screen and you can match anything you want because the analysis is on the data. You are not collecting data to do the analysis because the data is already there, which is kind of a reverse of what we are usually thinking about.
Oh, sorry. You're talking to me? Oh, you're done. Okay. No, this lady there. Hello.
Hey.
You mentioned about GLP-1 mutant. So with this test will be a guide to prescribe GLP-1 analogs or this medication, or why do you suggest taking this GLP-1 mutant test?
I mean, that was the suggestion there is like a research study, right? You can get 12 GLP-1 mutants or any genes in the systems that would affect it, right? And understand what are the consequent of phenotype, right? That would be more as a idea for a research study, not that we are doing it now, right? It's just that list was studies that are possible within the realm of this data set. But you can imagine even heterozygous for GLP-1, are they do they have an effect? GLP-1 with some other hit on the genome, and that's the studies that we can think about, right? But it's not an active study right now. That is a list of possible research studies that we could do on the genome.
Fantastic, brilliant. Thank you so much, Tiago. A big round of applause for Tiago.